Hello, everybody. See me in the back, all right? All the way in the back? Yes? If not, that's fine. I'll walk here, make sure everybody stays awake through the... All right. All right, guys. So I see some senior faces here too, but a lot of new batch here too. Can I see a raise of hands for the interns? All right. They're all on that side. Guys, did you scare them or something? All right. So, I'm Dr. Vadva. I'm one of the nephrologists here. And I've been here for close to a decade now. And you guys will be seeing us around when you guys do rotations on the floors, be it Loyola, be it BA side. Most of our renal faculty is on both sides of the street. And so it's really hard to escape us, no matter what you guys try to do. But without much more talking, we'll get started. And I know, Diana, you asked me whether we should try to do it as two separate lectures like we did last year, or should we try to do it as one. For those who attended it last year amongst the seniors, I've made few changes in the slides. We'll try to see how we can get through the presentation today. If we need to make another one, we did that last year, but I'm hoping the way it is going this time, we should be able to cover most of the cases. So, but again, you guys are welcome to participate as we go along. I've made it as a case-based presentation because a lot of you guys, when you come either to the clinics or you guys are on service, you'll be seeing these patients. So I've tried to put the clinical aspect rather than just making it like a didactic thing about different types of glomerular disease, because these are a very, very fun set of diseases to learn about in nephrology. You guys will see a lot of chronic kidney disease, acute kidney injury, but this is something that really excites all of us as nephrologists a lot more. So we'll just start by reviewing just the very basic structure of the kidney and what's the most important functional unit in the kidney, which is our nephron. And starting with the basics, you have the glomerulus. You have the proximal tubule, the loop of Henle, the distal tubule, and the collecting ducts. Majority of the gloom part is up here in the cortex that you see on the sides, and then medulla, you have more of the collecting areas here. Looking at the structure of the glomerular tuft, because this is what we are going to be looking at a little bit more in detail as we try to put what's happening. Think of yourself, traversing through one of these, and that's how the kidney is thinking when there is a process going on. So to look at the different parts of this glomerular tuft, we have the afferent arteriole, which then, there's several loops, capillary loops that it divides into. These capillary loops, they are lined by this endothelial cell. There is a basement membrane around it, and then there is a porocyte, which is the epithelial cell on the outside, which has small areas that we call as foot processes. We will be using these words a lot, so I'm just trying to clarify, and I'll point out as we go along in our presentation. So we talked about the afferent arteriole, these capillary loops, endothelial cell here, the basement membrane right here, the porocyte, which is your visceral epithelial cell, the parietal epithelium being on the outside. And then you have the mesangial matrix, which holds these capillary loops together in the glomerulus. The other term we will be using, we will also be looking at talking about tubules. And then outside of this glomerulus, there's the interstitium, which is the matrix which holds the glomeruli and the tubules together in the structure. So we are going to go over the molecular mechanisms of each of the glomerular disease we talk about. No, guys, I'm joking. Seriously. Don't take it so seriously, okay? That is really beyond the scope of any talk because there are mechanisms that we are identifying, very, very exciting things going on in this world about the glomerular disease. I'll mention few things as we go along, but we are not going to go into the detailed molecular mechanisms today. We are going to focus more on the clinical aspects and how do we put it together when we see these patients. But in general, there are inflammatory and non-inflammatory processes that will affect the glomerulus, which will result in alterations in the permeability, structure, and function. Now there are different pathways that can be involved, the humoral, cellular, complement activation, all of these pathways in one way, shape or other or form, they will be having the effect on the glomerulus, and we'll be talking about that as the final part of it. Now clinical presentation is what we will be focusing on, and how to put it together with how the patient presents, or what the findings are on the lab test that we see for the patients. Now histologic classification is also a way to go, and some of it will kind of intermingle as we look at it. I have the next slide where I'm going to go over what we are going to be talking about today in a little more detail. But you'll be looking at the light microscopy, immunofluorescence, electron microscopy. Whenever we do a biopsy in a patient, we tell them we are going to look at under 3 special microscopes. It makes us look smarter. Not really. But light microscopy, you look for processes. Is it something diffuse, that it involves more than 50% or less than 50% of the glomeruli? Then within each glomerulus, is it part of it or the entire glomerulus that's affected? Immunofluorescence, we look for all these different deposits. Nice pictures sometimes come out of, depending on which deposits we are looking at. And then the electron microscopy, where you can see these deposits in a much more higher magnification and in depth, and also it shows the food process effacement much better, which we cannot identify on the light microscopy. So we are, like I said, we can divide the glomerular disease, and it's really more how you look at it, but we usually use a combination of the things we talked about. So we look at the clinical presentation, nephrotic versus nephritic. We look at the etiology, primary versus the secondary, or systemic versus mostly renal involvement. So we will be briefly going over some of these in the case formats. So we can go ahead and get started. But nephrotic syndrome, we all know, minimal change, focal, segmental, membranous. When there's systemic involvement but presents as nephrotic syndrome, diabetes, amyloid, lupus is another one, drugs, malignancies, all these in the back of our mind. And I'll keep pointing out as we go from case to case as to where to think about what. In terms of nephritic syndrome, more appropriate term, we'll talk about it, but post-infectious IgA, rapidly progressive, very important, because these are the cases you'll be seeing very sick patients sometimes in the hospital, and there can be systemic involvement even in these. But others that have more of systemic manifestations and present that way are lupus, big ones. Alport can have multi-system involvement. TTP, we won't be able to cover that today, but some of the infections we are going to talk about it. So very briefly, just to refresh the memories from the medical school before we graduated, nephrotic meaning more proteinuria, low albumin, high cholesterol, edema. Nephritic meaning when we don't have as much proteinuria, 1 to 2 grams, or definitely not in the nephrotic range. Hematuria, very active looking urine sediment, we call it. That means they are atypical RBC with bunny ears and red cell cast in the urine, and these patients can be hypertensive. So with that, we'll go ahead and start with the cases. Some of these are mix-up cases, and the others are actually patients that we have seen here. The pictures are, I've taken them from either the mix-up or somewhere online, because it was not possible to get all the pictures for the patients that we have seen from Dr. Pekin. So 56-year-old previously healthy male presents with acute shortness of breath, right pleuritic chest pain. No fever or chills. For the past month, he has noticed swelling of his ankles. He has had no prior symptoms of dyspnea on exertion, PND or orthopnea. Please do not mind my abbreviations. I'm like you guys, not like some of the senior people who don't like them. I hope you understand them. If you don't, please feel free to ask. He has no joint pain or rashes. He takes no medications and does not smoke. On examination, the patient is alert, but in mild respiratory distress. He's little hypertensive, little tachycardic. Respiratory rate, as we all know, standard is 18 to 22. No JVD, no rash, lungs are clear. Essentially, most of the exam is benign, except the patient does have a lot of leg swelling here. In terms of looking at the labs, CBC looks okay for the most part, but look at the albumin here. Cholesterol is high. C3, the normal is about 80 to 130, so normal. C4 is about 25, normal is 20 to 40 or 50. ANA is negative, urinalysis is showing, so this is the renal function panel. Not too exciting to call the renal fellow just for this, but yeah, creatinine is 1.4. But when you look at the urinalysis, there's 4 plus protein, granular CAS, 3 to 5 RBCs, and you know, we were excited, so we did a 24-hour. We don't usually check the 24 hours, but we did it, so it's 10 grams per day. And the chest X-ray shows that the lungs are clear. VQ scan shows a mismatch in the right lower lung field, and the duplex scan of the renals shows a renal vein thrombosis. So feel free to say which renal disease is most likely in this patient. Good pastures, membranous, nephropathy, Wegener's, lupus, or microscopic polyangiitis. Come on guys, any thoughts? You can just, being an anonymous person shouting. I heard some mumbling. Yes, I think I heard it right. Did somebody say membranous? Membranous, excellent, excellent. So this is a very, very classic case. They will still ask in the boards. That's why I think it's still holding up in MixApp. So if you look at between the focal segmental, membranous, and minimal change disease that we talked about in the first slide as common causes for nephrotic presentation, at one point in time, this is, I'm talking 3 decades ago or so, when they did the biopsies, membranous was really at the top as most common cause of idiopathic nephrotic syndrome in Caucasian adults, especially males. Now, if you look at it in the last 2 decades or so, with more renal biopsies coming up in Hispanic and African American population, FSGS has caught up. So that is also another common, biopsy diagnosis. But in Caucasian patients, still this is one of the most common in United States. So nephrotic presentation in majority of the cases. Now this is another question they like to ask. I don't know why. You know, you can see a little bit of hematuria, 3 to 5 RBCs, just to throw you guys off. We will see these little bit of RBCs trickling down here, although it is more of a nephrotic process. Incidence of DVT, especially the renal vein, is more common with membranous than other forms in the smaller studies that they have looked at. We typically, you will have thrombosis, as we know, with the loss of certain factors, activation of certain other factors, being a little bit more procoagulable state in these patients who have nephrotic syndrome. What they have found is more than the amount of proteinuria, which we know in nephrotic patients will be, in a higher range, like 8-10 grams or so. The risk for DVT or renal vein thrombosis, they found it in those series is more associated with the albumin levels. If the albumin levels are less than 2.8 in the study that looked at membranous, or less than 2 in other types of renal disease that presents as nephrotic syndrome, then the risk of DVT, deep vein thrombosis, will be higher in those patients. Do we really go about empirically anticoagulating these patients? So our practice is a little bit different from Europe. In Europe, there's more data that, not more data, but the practice is that people will empirically start some of the patients. If you look at our practice in United States, the recommendations are, we don't have enough data to put the patients through the risk of anticoagulation, but once an event happens, then you will see these patients on anticoagulation for 6 to 12 months, or some say till the time they're still nephrotic, is it worthwhile to keep them on the anticoagulation. But as of right now, if they ask you in the boards, do we anticoagulate them empirically just because of the proteinuria? The answer is no. And what is it that's most important thing that correlates with the risk of developing DVT? It is the albumin levels. All right, so another very, very important thing. Now, idiopathic meaning we don't know the exact etiology, although we have identified, it's very exciting times, like I said, in this GN world. There is a phospholipase antibody, which is, we talked about the epithelial cell, the podocyte near the foot processes. There is an antigen located over there, and there have been antibodies that are now detected in about 70% of the patients with idiopathic membranous nephropathy. So The blood test is available. It's not the first thing we order if we diagnose membranous, but if we really think this doesn't have a secondary etiology to it, then it's something where you can think about checking it, but we are still cautious in interpreting it too much. But the test is available, and like I said, it's very exciting. A lot of work going on in that field. Now, secondary meaning that there can be other etiologies for it, infections being one of them, hepatitis, big one on our list, certain drugs. Earlier there was much more use of gold or penicillamine. We don't see that. Lupus, I'm going to talk about that when we get to lupus, and certain malignancies, solid organs. So you will see that if we diagnose a patient with membranous, or we are thinking that, we would say age appropriate malignancy workup. Sometimes we may get a little more aggressive if they are a smoker. Now we do the low dose CT scan to look for things. So those are the kind of tests we would ask, because before treating these patients, we absolutely want to make sure we are not missing a secondary etiology for this membranous. Okay, so very quickly, I don't think these pictures came out that well. This looks nice here. So normal capillary loop, like we talked about, the endothelial cell, the basement membrane, the podocyte on the outside with the foot processes. Like I said, in this epithelial cell, that's where they have identified the PLA2R antigen. So these antibodies come and these big deposits form right here. They're called subepithelial deposits, which is the hallmark that you see in these patients. And when you look at light microscopy, the basement membrane is very, very thickened compared to otherwise normally it should be nice thin open loops of glomerular capillaries in there. If you look under the immunofluorescence, the pattern is IgG and C3. That's what you see as deposits. And electron microscopy, again, underneath the epithelial cells called subepithelial deposits. That's what we would see in these patients. Now, how do these patients, in terms of treating these patients, what do we do? So actually, the rule of 1/3 applies in these patients because the course is variable. If you take a look at these patients, sometimes we will really, like nephrology, they don't do anything much when we even refer with such exciting findings. But the thing is that about 1/3 of these patients, they will undergo spontaneous remission without any intervention in a period of 6 to 12 months. The patients in whom, let's say, we did start ACE and ARB and we followed them for 6 months or so, but the trend we are seeing is that either we are seeing a change in the renal function, or we are seeing that the proteinuria is staying in the nephrotic range, especially more so around the 8 to 10 gram mark. Those are the patients that end up getting identified as the ones that we are going to go ahead and treat. The ones that are really rapidly progressive would be the ones we would treat. Otherwise, those with 2 to 3 grams of proteinuria, creatinine hanging around 1 to 1.5, most of those patients we would not treat. And treatment, is again, it's not very simple. It's pretty aggressive. The cytotoxics that we use, cyclosporin, cytoxin, and again, not very simple to treat, but a lot of them do respond. But again, we don't treat every membranous patient. Renal survival usually good at 10 years is about 60 to 80% in these patients, with or without treatment, especially for the low risk group. All right, guys, so we'll move on. Any questions so far, either on the basic renal pathology or the first case we talked about? All right, so we'll keep moving. So in this case, a 17-year-old student presents with a 2-week history of periorbital and lower extremity swelling that developed over 3 to 4 days. So looks like this is a very, very sudden onset as opposed to like a month or 2 of something going on. The patient had been well up until this point, doesn't take any medications, no drug use, very important, not really hypertensive, pulse is okay, afebrile, but he just really looks extremely puffy. Again, the labs, like I said, some of you will notice I was a little lazy about not changing the labs in most of the cases you're going to see, except for the fine things that we need to know about. So here, the protein is the same, albumin, as we know, is low. Serologic studies were all negative. This time I didn't even copy-paste them. Urine analysis, 4 plus proteinuria, no RBCs. Again, we did a 24-hour. I don't know why we get excited, but 10 grams per day. So here are the renal biopsy findings. 15 glomeruli, light microscopy is normal, immunofluorescence non-specific staining, and electron microscopy with fusion of the processes of the photocytes. So based on the clinical presentation, the findings of this biopsy, the diagnosis you guys need to know on this electron microscopy to graduate from medical school, guys. What is the diagnosis in this patient? A, membranous nephropathy. B, minimal change disease. C, membranoproliferative. D, focal segmental. E, Alport's. Excellent. So I heard minimal change disease. Very good. This is the very, very basic. We know everything looks good on the biopsy except on electron microscopy you find these changes. Let's look at another case. 60-year-old with hypertension and osteoarthritis. He was referred, actually this was one of the patients during my fellowship that I saw. Referred to the renal clinic, and it was a VA patient for acute renal failure, new onset proteinuria, 30-pound weight gain. He says his urine is so frothy. Exam, he's hypertensive, he's anasarchic. He does have history of hypertension baseline also. So he was on diuretic, but they replaced it with furosemide because he was just developing so much edema that they were not able to really control it with the hydrochlorothiazide, and he's on the naproxen for his osteoarthritis. Now his labs, CBC looks fine. He does have hypoalbuminemia here. Total protein is okay. The serologic studies, again, I'm giving you are negative. If you look at the renal function panel, he is in acute renal failure, as we know of, at least here. We know from the history it's acute, and we know that it's new onset proteinuria because he probably didn't have it before. Again, the 10 grams of proteinuria, he is not diabetic. So again, we have a renal biopsy finding, same 15 glomeruli, light microscopy, normal glomeruli, but there's interstitial inflammatory infiltrates, some years. Immunofluorescence, again non-specific staining, and electron microscopy shows fusion of the food processes. So based on the available data that we have, the case that we looked at and the biopsy findings, which renal disease is most likely in this patient? Post-infectious GN, minimal change disease, Alport's, lupus, or diabetic nephropathy. Any thoughts? We'll probably modify the diagnosis a little bit for next time. But any thoughts? Very, very interesting case. An elderly patient, no previous history, is now presenting. Very good. Did I hear someone say? So again, all you see, the glomeruli are completely normal on the light microscopy, right? So very similar to what we saw in the previous patient, right? This fusion of the food process is very non-specific also, that can be, but there's nothing else other than a little bit change in the interstitium. But definitely this goes along with the 10 grams of proteinuria that you're seeing with the patient. That's where the damage is, and that's where the protein is leaking from. So this is a patient that you should know from adult minimal change disease standpoint. So this patient, as we said in the history, was on naproxen for his osteoarthritis. This is the classic presentation that you'll see in NSAID-induced glomerulonephritis, where you will have interstitial nephritis, severe interstitial inflammatory infiltrate, but otherwise the classic finding other than that from glomerular standpoint will be minimal change disease. This is something they love to ask in the boards too. But again, anytime you have NSAIDs, there's a spectrum of exciting disease that can go along with the NSAIDs, and you'll see we banned them from our renal clinics and everything. But you know, they cause hypertension, electrolyte abnormalities, but from glomerular standpoint, this is the case you will probably see along the way somewhere, you know, in your practice. So like we said, you know, typically in minimal change disease, all you see is, so to orient ourselves, light microscopy, but again in electron microscopy, you have these food processes. These are the ones that are effaced. Otherwise, there's nothing in light microscopy in typical minimal change disease we talk about. In fact, in pediatric population, in younger kids less than 10 years of age, if they present with nephrotic syndrome, most of you know, they are not really biopsied. They are given a trial of steroids to see if they will respond to it, because that's how common minimal change disease is in children. But the presentation in adults can be different. And this is how it would present in, we talked about one specific scenario where there's interstitium that we talked about outside the glomerulus or the tubules. So there's a lot of activity here, interstitial infiltrate. So minimal change disease, like that I said, more than 90% of the cases in children with nephrotic syndrome are minimal change, but in adults it's a smaller percent, 5 to 10%. Usually sudden onset, heavy proteinuria, there will be edema, light microscopy, nothing in light. It's also called nil disease, or used to be called. Immunofluorescence, there'll be no deposits, and electron microscopy, only thing you'll see is food process effacement. So even in adults, when we treat these patients, not for the secondary causes like the NSAID induced, so that patient from the VA that we had, we did not treat, we just stopped the non-steroidals. It took him about 4 to 6 weeks for the proteinuria to get a little bit better. We just had to escalate the diuretic regimen, and after that, over time, he came back close to his previous baseline for the renal function. So not completely normalized, but the proteinuria completely went away to nothing in a matter of 6 weeks or so, and we discharged him from our clinic. But in adults, if you are, if you're suspecting that this is idiopathic, that means there's no secondary cause for it. And two very, very important secondary causes to look for: hematologic malignancies, especially lymphoma. We are very, very cautious before we treat adult minimal change disease, because we may be partially treating a lymphoma or masking that. So we want to be sure there's nothing like that going on. But even in adults, a lot of them will respond with either partial or complete remission to the steroids. So the response to steroids is still pretty good, although they may be steroid dependent, or whenever we try to, take away or taper down the dose, they just relapse. So relapses can be higher. All right, so we'll move on to the next case, guys. We'll keep going. So 50-year-old African American woman. This is again a patient if you come to my clinic, you may get to see her sometime. No significant medical history, presented with increased leg swelling over the last 2 months. She denies any travel history, no drug use, no recent illnesses. She was hypertensive. She did have significant lower extremity edema. Labs on this side never change, the same. On this side, what we have is, creatinine's about 1.6. Urine analysis again with 4+, proteinuria, granular cast. So move the cursor a little bit from 10 to 8 grams per day of protein. What are you guys thinking at this point in time? Oops. I gave it away, sorry. So we talked about membranous, right? In Caucasian population, 30% of the biopsies these days are still with membranous, a common cause in United States. Then we talked about minimal change disease, which presents as nephrotic syndrome. And the third one in the line is FSGS. This is something which is, you're going to see it a lot more, because there are more biopsies that are happening, but now we are finding out that in African American population, very high risk, has been linked to a gene MHY9. Again, very exciting field for us right now. A lot of patients in whom we had a little bit of proteinuria, we didn't know before what was going on. There may be some inherited pattern to that and some linkage to that gene. So it's been looked at, and these patients, some of them do end up progressing to ESRD, quite a few actually. So like I said, we are diagnosing it with more and more frequency, and it is the most common form of glomerulonephritis in our African American patients. They will have all these findings of hypertension, microhematuria, renal dysfunction. Now, this is interesting. The focal segmental glomerulosclerosis, it's not as steroid responsive as is the minimal change disease. In fact, if we treat patients with minimal change disease and they are not responding, sometimes we think of rebiopsying these patients, because we are biopsying one specific area. I feel like I've been ignoring these seniors here. So one specific area, so if the process is not very diffuse, if it's focal, then we may end up missing, FSGS. And that could be the reason the patient didn't respond. So that is a thought that should always cross our mind also when we have a patient with minimal change disease, especially if they're not responding. Think of focal segmental glomerulosclerosis. The course of the steroid sometimes is a little bit longer that's required. Again, we have the steroid resistant and the dependent patients in whom we have to use different other different agents. For this patient, fortunately, she responded very, very beautifully. Within 3 months, she was absolutely didn't have any proteinuria. She's following with one of you guys in the clinic, resident clinics, and with me. But then she relapsed exactly 2 years later, and then the moment we started her on steroids, all that protein melted away again, and within 3 months again, you know, she responded very, very well. Now she's doing good. For the last 1 year, she's been off of the steroids completely. But FSGS primary sometimes can be very, very tough. You know, I have inherited few of the pediatric patients who, you know, we don't want to keep using the steroids for very long. They have been tried on other things. You know, some have come to me with cyclosporin for several years now. There was a girl we had, she's, you know, we're trying to take her off of that because now she's becoming hypertensive. So some of these patients can be very difficult and tricky to treat over time. But couple of things to remember about focal segmental: half of the patients will still respond. That if it is primary FSGS, that is what we are thinking, then we want to treat them with steroids, and most of them will respond, at least half of them, with a flip of coin. And the other one that I talked about with the MHY9 or some other factors that we see in African American population, they will have recurrence. So you'll see when you refer these patients for transplant, because they end up on dialysis and their etiology was focal segmental, transplant is going to be extremely cautious. They would be monitoring the patient day one from the day they get the kidney for how much protein is in the urine. They'll be tracking them as the patient goes along. So there are some variants to it you guys don't really need to know, but just to make it not so boring, a little bit more about FSGS. You know, they have different types. It may be close to the hilar, most of the sclerosis that you see. It may be close to the tip. It may be a collapsing, which you will hear. That's why it's important to know this one. Cellular, you know, no one talks much about it. The reason it's important to know this one, because you will hear about the collapsing FSGS with certain kind of, I think I have it in the next slide after that. But one is their overall prognosis, depending on the type of lesion. So we will just simplify this slide as the solid line is the collapsing and all the others are dotted here. So if you look at the renal survival, it is the worst with the collapsing FSGS. With all the others, it's better. With the tip lesion, it's usually the best. And again, very, very important to see this, that there are secondary causes to each one of these lesions that we have talked about, not for FSGS, but minimal change, you know, secondary causes for that, membranous, and then for FSGS. Again, it's a pattern and the etiologies can be different. We have to make sure we rule out the secondary causes before we label it as primary or idiopathic. We cannot do that based on the biopsy alone. So the history is very, very, very important for us in all these patients. In HIV, we have seen collapsing variant a lot more, at least before the advent or when the patients are not taking their heart therapy. Heart has changed the landscape of what we see as HIV nephropathy these days on renal biopsy. Some viral infections, drug use, pamidronate, very important. We have seen this actually in few patients. So in addition to the jaw complications of it, from renal standpoint, this drug sits in the system for a long time, especially for patients with weaker kidneys, CKD and ESRD. We don't even use it in ESRD patients typically, but it has been shown to cause the collapsing variant of FSGS, which is the worst prognosis. Same with sirolimus. We actually started using the sirolimus. So for renal transplant over time, 1980s, cyclosporin changed the landscape of the renal transplant when it came along, because the renal survival improved drastically in those patients. But over time, what we saw was the chronic changes related to cyclosporin in the kidney. So in some patients, they are more sensitive to these calcineurin inhibitors, like the Prograf and the cyclosporin. So we have tried sirolimus in some of those patients. In fact, those of you who know Dr. Ho's time, she started to switch some of the patients around. But what we saw was with sirolimus, more and more cases of proteinuria started to come out. So we have to be very, very careful. On one end, we are worried about renal function declining because of the CNI toxicity in these patients, not just renal, but other solid organ transplants too. And then with the sirolimus, we monitor the proteinuria. So some of you who will see some of the heart transplants or others in our clinics, you'll see if we have them on sirolimus, we will be asking you, did we have the urine studies? Did they have proteinuria? How much proteinuria did they have? Other than that, others are pretty self-explanatory. Sickle cell is another one. I think they do ask on the boards. This is the lesion that we see with sickle cell. And again, in these cases, in the secondary, it's really stopping the medication if that's the case, or treating the underlying cause for it, not so much treating it with steroids. A word about, since we are talking about nephrotic presentation, not just nephrotic syndrome, but diabetes. If you look at the landscape of end-stage renal disease, this is the United States data from 2014 report. So from all causes of end-stage renal disease, diabetes tops the list. About 40 to 50% of our patients who are dialysis patients, which is close to 500,000 here in 2014. The etiology was diabetes. The next one is the hypertension, and followed by the glomerulonephritis, other types of glomerulonephritis that we are talking about. So again, it is the leading cause of end stage for incident and prevalent patients. When you guys come to our clinics, you're going to see a lot of diabetic patients with proteinuria in there. Do we biopsy all of them? We don't. We really look for patients who may have any kind of atypical presentation, and we would biopsy them. Not too long ago, I had a young guy. He looked really good clinically, hard to believe, just walks in, and he does have a long-standing history of diabetes, but he lost 200 pounds like 15 years ago, so now he looks really good. I just could not explain how rapidly his renal function was going down in the year that I saw him. I ended up biopsying him, but we only found extensive, renal injury from diabetes. So it's just that we do see that rapid decline in GFR in some of these diabetic patients in the very last stages, when the renal function just goes down in a year's time. We see significant, not just a 3 to 5 ml per minute loss, but 10, 15 ml per year. In a matter of last 1 or 2 years for some of these patients. But anytime we feel like, this doesn't sound very typical, for one reason or the other, we will go ahead and biopsy these patients. Again, the findings would be, you'll see like a nodular kind of a kidney, but all this hyaline deposit with, matrix deposition and really irreversible changes with the scarring, thickening of the basement membrane, and nodule formation. All right, guys, moving on. Any questions so far? Okay. So 65-year-old white male with history of hypertension admitted for workup of syncopal episode. He had several episodes of dizziness over the last 2 months. Exam is normal except for macroglossia, a big tongue, and orthostasis. I'm giving you multi-system kind of an involvement here with whatever I'm talking about, right? He has orthostasis. He has a tongue that's really large. This side of the story doesn't change much. Albumin is still in the juice. Total protein is low. The CBC looks fine. The renal function looks actually pretty pristine. Nothing really very striking over there. But when you look at the urine, again, 4+ proteinuria and 24-hour urine with 10 grams of protein. Chiefs, let me know if I should change this next year. But I really like the 10 gram 24-hour. But the message is we don't check 24-hour urine collection in these patients, please, guys. This is just to keep you awake. All right. So the renal biopsy is showing that there is some deposits, and the buzzwords on your boards or elsewhere would be weekly staining for PAS, because it's not the classic deposit that you see on the renal biopsy, but it looks pink when we stain it. And you'll see it in the mesangium, you'll see it in the capillary loops, And that's why the capillary loops are kind of all closed up here or kind of pushed to the sides. And the Congo red stain is positive for green birefringence. Any takers on this? This is pretty straightforward. I think I heard. Excellent, excellent. So this is amyloidosis. So anytime you're seeing a presentation that involves multiple systems, orthostasis, macroplasia, syncope, and it's presenting this way with nephrotic presentation from the urine standpoint, think of amyloid. There could be more cardiac involvement too, but think of amyloid. So basically what it is, there are many different types. We are only going to touch upon the 2 of them that I've listed here, and again no more slides of this. But AL is amyloid light chain. So basically you have a lot of light chains and somehow they get misfolded by attaching to another associated protein that's there somehow in these patients who have amyloid. It goes and deposits in the tissues, in different tissues in the body. You will see it in the GI tract, you'll see it in the heart, you'll see it in the kidney, and like I said, in the kidney you'll see it in the mesangium, and you'll see it in the capillary loops to some extent, a lot more in the mesangium. So that's why you see the proteinuria from the renal standpoint. So it's a misfolded protein, lot of thoughts out there what causes them, the local environment, the protein itself, the side chains that are associated with these proteins. So but they form these insoluble fibrils and they cause organ dysfunction when they present as amyloidosis. And like I said, light chain amyloid, AL amyloidosis, this is the most common form, and you have the variable portion of the monoclonal light chains here, could be lambda or the kappa. Little bit older patients, we have seen patients in their 50s too here, more men than women, but you'll see a mix of them. We had a woman around 50s, and not all of these patients will have myeloma. Okay, so myeloma kidney that we talk about, where there's deposition of these light chains but in a different format and in a different site, all of these patients will not have plasma cells producing those myeloma cells, in a more than 10, 15, 20% of the bone marrow cells. So they may not have overt multiple myeloma or Waldenstrom's with the IgM, but a small subset of them may still have multiple myeloma. AA, that is the amyloid associated. Now this is more of a secondary form, as we say, because it's associated with chronic disease. So some of you who come with us and see our veterans on the other side of the street, spinal cord patients who have chronic ulcers for a long period of time, suprapubic catheters with chronic infections going on there. We don't biopsy a lot of them, but we have biopsied few of them in the past, and when we find amyloid, it's generally the reactive amyloid going on due to chronic inflammation. But you can also see it in patients with rheumatoid arthritis. So actually, if any of you comes to my VA clinic, I have a patient with rheumatoid arthritis. We have biopsied him. Doesn't have as many renal manifestations with the amyloid, but he does have amyloid deposits on the renal biopsy. All right, so one other point in terms of clinical presentation for amyloid, because light chain deposition disease versus the amyloid, again, like we said in amyloid, this protein is going to fold in certain forms and go and get deposited in certain tissues. But it may not take the form of amyloid, which gives you the typical fibril appearance. The light chains deposition disease, where the light chains may just by themselves in large amounts go and deposit in certain tissues. So the renal presentation for 2 can be a little different, because when you have light chain deposition disease, you may not have as much proteinuria, but these patients present to us with acute renal failure. So they'll present with creatinines of 4 or 5, as opposed to amyloid patients where they will have massive proteinuria because they're causing the damage to the glomerulus at the capillary loop and the mesangial level, but they're not damaging the tubules. These light chains, when they go, they knock out the tubules. There's a lot of interstitial process. The glomerulus gets choked in a way. So they present with renal failure, but amyloid patients in general, they will present with proteinuria. So a very, very different presentation at least in 50 to 60% of the patients, this is the classic presentation. If they even give it to you on the boards, this is how the presentation should be. And of course, if it is AL amyloid, we send them to Dr. Nan for further workup. All right. So I can continue, guys, or we can stop here because I'm starting the nephritic. I really thought I would be able to carry on and complete the cases. But I can go over this one case and then we can decide whether we want to do another one, or you guys will hear all of this when you come to the renal rotations, because we do this almost every month. One of us will be doing this, and if you guys are interested, you're welcome. We have the schedule posted outside the renal office. So 23-year-old Hispanic woman admitted with shortness of breath, cough, increased leg swelling, abnormal labs. Noted to have facial rash, face and leg swelling for 2 weeks, no history of travel or sick contacts, chest x-ray with bilateral effusions and infiltrates. So here we have somebody with anemia, thrombocytopenia, leukopenia, hypoalbuminemia, there's proteinuria, and there are a lot of red cells. And if you look at the urine, there's the red cell cast, very, very active urine sediment, about 6 grams of protein, still in the nephrotic range. Thank God we stopped checking the 24-hour here. And if you look at the renal function, this patient is in renal failure also. So a young Hispanic woman with multi-system involvement of, you know, the hematologic aspect of things, and from the renal standpoint, an acute renal failure. We further go on to check the complements, and both C3 and C4 are low. ANA is off the roof, so it's the double-stranded DNA. Any thoughts, guys? What are we thinking at this point? And there's no way you guys will escape seeing this in your 3 years here. Actually, very, very sick patients we have seen come through almost on their deathbeds, but these are young women. Fortunately, they have a lot of potential and reserve. Majority of them will bounce back or recover. We just have to be very, very aggressive in treating them. So renal biopsy findings, the big thing to remember, and I have a classification of lupus in one of the slides after this, that there is a lot of activity going on in the glomerulus here. You know, the normal open nice capillary loops, they are all occluded here. There's a lot of inflammatory infiltrate going into this glomerulus, and what you may even see is that, you know, there's so much proliferation of cells here that it almost pushes this glomerulus to one side. We call this a crescent. So that's very, very high cellular proliferation that's happening over there in the glomerulus. So very, very active disease. Now the other classic feature about lupus that you have to remember is, you know, all these different stains for immunofluorescence that we talk about, IgG, IgA, IgM, C3 and C1q, you will see this is called the full house pattern. You have all the complements, you have C1q, and you have the C3. All of these will be seen. I don't have the immunofluorescence pictures here, but if you look at the immunofluorescence, you will find it to be positive 2+, 3+ for all of these complement components and the immunoglobulins. In the glomerular capillaries and the mesangium, you may see it in some of the tubules too. And electron microscopy wise, in this patient, again we'll orient ourselves real quick here. So this is one of the capillary loops. If we look at it, this is the endothelial cell here. This is the red cell in the capillary loop, right? And this is the mesangial cell around here. If you look at the D, that's the deposit, the dense deposit. This is the urinary space that we talked about. That's where we had all the food processes. So this deposit, as you can see, is inside of this basement membrane and underneath the endothelial cell. Okay, if you remember in membranous, we talked about the deposits were underneath the epithelial cell, which is in the urinary space, the podocyte with food processes. But here we are looking at a deposit which is underneath the endothelial cell. This is the endothelial capillary loop we are talking about. Again, another mesangial cell. This is another deposit. So diagnosis we already talked about, we think. Now this is a little bit of a busy slide, but only reason I put it there to simplify it for you guys and to correlate the findings of lupus a little bit with the clinical picture, because that's what our thought process is when we get patients either from room because they have proteinuria or they have isolated hematuria, and we co-manage a lot of these patients with rheumatology, and we actually have combined renal and rheum rounds every few months now. So, but if you look at this classification, this is the newer classification. The first one here, minimal, we are not thinking there's not going to be any of much findings. We really don't biopsy because there's not any clinical findings with this at all. We really save the biopsy in these patients for the times we think we are going to be changing our management, because these patients over their lifespan will require more than one biopsy, some of them. Now mesangial, meaning, remember we talked about the area which is the supporting structure in the glomerulus, that's the mesangium. If we are seeing just the deposits there, that the disease is just starting to take or work in there a little bit, all you're going to see is maybe few red cells trickling down and some little bit of hematuria, maybe microalbuminuria, but may not be. So from clinical standpoint, if there is mesangial, you're not going to see the case that we saw just now. Combining 3 and 4 together, either one, although we say this is the one that will classically present like we talked about in this case, but even we give benefit of doubt to patients, because again we said we don't know if we are just sampling a smaller area and don't know if more than 50% or less than 50%. So if we have proliferation going on, we really are aggressive in treating these patients, because the sooner we can get to them, the sooner we can calm down these things, the better it is. Then, so that knocks out our first 4 here, where we are saying here we are going to have maybe a little bit of red cells trickling here or there, and essentially no to microalbuminuria or very minimal proteinuria. 3 and 4 are the more aggressive forms, diffuse or proliferative or focal. We are very aggressive about it. Then coming to membranous. Remember when we talked about the first patient with membranous, I said I'll come back to it. So some patients will present with just a membranous nephropathy on biopsy. Let's say we have a 40-year-old or a 30-year-old woman who presents with a membranous lesion on biopsy, has proteinuria and all. We are very, very cautious in those patients, because we follow them over time, and some of them will develop positive ANA or will develop lupus manifestations over time, a small subset. So we can see membranous nephropathy, which can be part of, we already have a diagnosis of lupus and biopsy findings are membranous. But if we identify a patient with membranous, we always look for a secondary cause like lupus in those patients. Now, how will the lupus patient who has membranous present? Again, there can be an overlap, but in general, membranous has subepithelial deposits like we talked about, and these patients will present more with proteinuria as opposed to a very active looking urine sediment or red cell cast in there. So if you see lupus patient with 4 or 5 grams of proteinuria, before we are biopsying the patient, we are thinking this is probably membranous. And in a lot of these patients, the complements may be normal. Otherwise, lupus is a classic, thing where you have hypocomplementemia. But in these patients, few of them, unless they are getting consumed in a systemic form, some of them will have normal complement. So you will see this variant in our clinics. Not very good treatment options available for this one, but there are options that are there that we discuss with the patient. We still treat them if we think this is getting rather aggressive. Now lupus, and not much we can do with this. This is almost we start preparing them for dialysis here. So in a nutshell, to simplify it, very aggressive. This is a different lesion in itself. This one, we leave these patients alone and follow them very, very closely. And this one, there's not a whole lot we can do about it. We have patients with that also. So in terms of treatment, very briefly a word about the treatment for the lupus part. We kind of divide it in 2 phases, where we have the induction and the maintenance phase. But what we are basically doing in the induction phase is we are aggressively trying to treat or calm down the lesions in the kidney. And then in the maintenance phase, it's very hard to say how long the data is lacking, but most of us have patients for a few years. We have kept them on the maintenance regimen, and we try to taper it slowly. And if we feel like they're gonna, it's hard to predict the relapses. Depending on partial remission, or complete remission, we try to monitor, but again, very, very hard. So those are tough decisions that we make with the patients, that if we take you off, something flares up. And there are patients who are not going to be able to afford the medications. They'll come in with relapses here and there. Some of you may have seen one of our patients who was here just 2 months ago, again, presented after 6 months of not showing up or not being able to. So, but again, very aggressive. Again, another thing to watch for in these patients, while we talk about this, we had a patient not too long ago that was transferred to us with lupus nephritis, very aggressive, got a dose of Cytoxan. He would just not wake up. And he was, of course, intubated in the ICU. And over time, we found that, the immune system in itself is altered in these patients. There was a lot of debate, should we do the second dose of Cytoxan, because all his hematologic and other parameters look pretty bad, and Cytoxan in itself can cause leukopenia. And thankfully, we decided not to do the second dose of Cytoxan, but because he had some lesions that developed in the brain over time, there was concern whether this is lupus cerebritis versus it's an infection. And over time, we finally got to get the brain biopsy, and it was aspergillus. So again, on both ends, while we are aggressive about it, we have to make very, very thought out decisions for these patients as teams, whether we want to really treat and how much we want to treat. Because at that point, we told the family that, we can live without the kidneys, but if we make him get consumed by a fungus infection here. Fortunately, his kidneys also recovered over time. He still follows in the clinic, followed with all the subspecialties here. I think cardiology was involved, ID was involved, rheum and renal were the big ones that were involved. So I think with that, I will stop here. I have a couple of other cases. I think we got to the 6th case, so I have 3 more. But we can do that maybe at some point in time, or when you guys rotate to renal, I'll be happy to go over the whole presentation with you guys. Yes, Ivy. No, so calcium inhibitors are your Prograf or the tacrolimus and the cyclosporin, and between one or the other, it doesn't matter. It's the patient sensitivity, plus it depends what kind of transplant we are talking about.